our data collection forms. We obtained basic demographic information and then also their experience of simulations before this session. We then used Likert scales to for the students to self-rate their confidence levels in managing acutely unwell children, team working and communication. And then at the end of each form, we had a free text section which the students could expand on what they wanted or had gained from each session. So we obtained 143 pre-session responses with 123 post-session responses. It is worthwhile noting that, particularly for post-session responses, they didn't have to fill in the questionnaire in front of the facilitator. In figure 4, we can see pre-simulation, majority of students rated themselves as not very confident in managing an acutely unwell child. However, post-session, we saw that their confidence level had raised and that they were now rating themselves as confident in managing a critically ill child. This was shown to be statistically significant with a p-value of less than 0.001. And then in terms of communications with their colleagues and the patient or carer, and then team working, which are shown in figure 5 and 6 respectively, we can see that pre-simulation, the students had rated themselves more confident compared to management, and that there was still an increase in their confidence post-simulation, however, not as much compared to the management aspect of the simulation. Again, this is still found to be significant with a p-value of less than 0.001. Figures 7 and 8 show word cloud analysis of the free text responses. And we can see in figure 7 that the main skills the students wanted to achieve from pre-session was management and confidence. And then looking at figure 8, we can see that one of the main skills they developed was indeed the management. They also achieved confidence for a much lesser capacity. So based on these results, we feel that our adapted simulation still fulfilled the aims of enabling students to improve their confidence in managing acutely unwell children, along with associated skills of communication and team working in that environment. However, we did have a number of limitations in the fact that this was a single center study with the students self-reporting the data, and their performance in the simulation was not tied to their data. There was also variable experience of simulations before the session among the students. And then the last major one was difficulty in standardizing students' experience in the session. And this is predominantly due to technology, with Microsoft Teams dropping out, for example, or the mannequin just not working for that session. So in future, we plan to continue teaching with our current setup, as we think we've demonstrated that it is still effective. However, to review this in accordance with COVID-19 restrictions, hopefully easing, to maybe build it into a more MDT approach simulation. And also to discuss with other teaching sites and specialties, share ideas on how they adapted their own simulations to COVID, and if we can bring any of their ideas across to our simulation. So thank you very much.